Thanks for having me. النهارده هتكلم على rational use of antithrombotics in nephrotic syndrome. Why to give and when and for how long. Back to basics. First, nephrotic syndrome is a glomerular disease with characteristic proteinuria أكتر من 3.5 gram per day, hypoalbuminemia, dyslipidemia, and edema. It's associated with a hypercoagulable state, increasing the risk of DVT and RVT. The greatest risk is shown with membranous nephropathy, followed by MPGN, and then mild change disease. That's due to complement activation to produce C5b to C9. MAC, which is a part of the complement, attack the podocyte, which apparently prevent protein loss in urine. So podocyte injury leads to non-selective proteinuria. Pathogenesis is mainly due to the imbalance between the antithrombotic and the prothrombotic factors. In nephrotic syndrome بيحصل urinary loss of antithrombin 3 and reduced protein CNS, increased hepatic synthesis of prothrombotic factors like fibrinogen level and factor 8, plus albumin loss, increase of the free arachidonic acid, formation of thromboxane A2 leading to platelet aggregation. That's why in certain condition we could give aspirin as prophylactic in nephrotic syndrome patients, although it's a hypercoagulable state. So when to prescribe a prophylactic anticoagulant? So first of all, before prescribing a prophylactic anticoagulant, we have to balance this risk against the risk of bleeding. If it's a high risk of bleeding, prophylactic anticoagulation is a contraindication. So first of all, risk assessment. Risk of thrombosis has been found to be the highest in the first 6 months of diagnosis. Risk of thrombosis mainly depends on the serum albumin and risk of bleeding. Earlier, the risk of bleeding was estimated using the atria score, which is the anticoagulation and the risk factor in atrial fibrillation. It mainly depends on age, gender, and comorbidities, yet it's limited to the membranous nephropathy and it's not the best predictor of bleeding. Nowadays, we just use Hesblit. Again, if it's a high risk of bleeding, no prophylactic anticoagulation. There is an additional risk factors like prior thrombosis, genetic predisposition for thrombosis, antiphospholipid antibody, which is a really important one, immobility, obesity, pregnancy, and surgery. So first of all, before prescribing a prophylactic anticoagulant, we have to distinguish it's either a membranous nephropathy or any other type. We have to estimate the Hesblit and the serum albumin. So it's if a membranous nephropathy with low risk of bleeding and serum albumin at any level less than 3 gram per deciliter, we have to give warfarin to target INR 2 to 3 or enoxaparin 40 milligram daily. If Hesblit equals 2, هندي prophylactic anticoagulant if serum albumin less than 2.5 gram per deciliter, or from 2.5 to 3 gram per deciliter if there is an additional risk factor, as I've mentioned before, like genetic predisposition, heavy proteinuria. If it's a non-membranous glomerulonephritis, Hesblit from 0 to 1, هنا السيرم albumin cutoff مختلف. لو less than 2.5 gram per deciliter هندي prophylaxis. Hesblit equals 2 بندي prophylaxis لو serum albumin less than 2 or from 2 to 2.5 with an additional risk factor. If Hesblit equals 3 or more, no additional anticoagulation. So prophylactic anticoagulation in certain population like pregnancy, we could give a low molecular weight heparin if it's a low risk of bleeding, or if the serum albumin is less than 3 in membranous nephrotic, or less than 2.5 in other type. By the way, low molecular weight is an appropriate agent. Warfarin should be avoided because it crossed the placenta and caused teratogenic effect, yet it could be used postpartum even if she's a breastfeeding mom. Drugs should be avoided in pregnancy. Another special population, which is the antiphospholipid syndrome, if the patient is an antiphospholipid positive, we could give a prophylactic dose with a low dose of aspirin. The duration. امتى هفضل مكمله prophylaxis anticoagulation؟ هو optimal duration is still not well defined, yet أنا هكمل till يحصل nephrotic syndrome remission or إن السيرم albumin يكون أكتر من 3 gram per deciliter or equal. احنا كده خلصنا prophylaxis، هندخل على التريتمنت. التريتمنت عندنا أكتر من option, which is heparin bridge to warfarin, low molecular weight heparin, and drugs. First, warfarin has a drawbacks, which is a highly protein-bound drug. INR should be monitored frequently. It has many drug-drug interaction with CNI, especially like calcineurin inhibitors, cyclosporin, and tacrolimus. Drugs are more favored دلوقتي عن إن هي rapid onset of action, lack of monitoring, reduced bleeding profile, less drug-drug interaction than warfarin. Yet, their role in nephrotic syndrome is not yet well defined. Doses of drugs in venous thromboembolism treatment and prophylaxis. Just make sure that dabigatran and rivaroxaban should be avoided in creat clearance less than 30 ml per minute. In antiphospholipid syndrome and the first venous thromboembolism, the first line is warfarin with a target 2 to 3 is recommended. Rivaroxaban should be avoided in patients which have triple APL positivity due to high risk of recurrent events. طيب what if in the patient كان على warfarin on target 2 to 3 yet there is the recurrent venous thromboembolism? We have 3 solutions, whether to add a low dose of aspirin or to consider low molecular weight heparin or ان احنا نزود التارجت from 3 to 4. The non-inferiority trial but evaluated safety and efficacy of rivaroxaban against warfarin. لقينا ان rivaroxaban البيشنتس اللي اخذتهم جالها recurrent thrombosis plus ان هو showed non-inferior عن الورفرين. دلوقتي هنتكلم على الدواكس used in nephrotic syndrome, safety versus efficacy regarding the case studies with case reports. The point is in the evidence of dwacs used in nephrotic syndrome is extremely limited, consisting mainly of randomized trial وmainly case reports. والcase reports أكتر على التريتمنت أكتر من البروفيلاكسس. فأول randomized trial في 2017 but evaluated safety of rivaroxaban against the low molecular weight heparin patients in nephrotic syndrome. البيشنتس عندهم low level of antithrombin 3. احنا قلنا قبل كده ان في nephrotic syndrome بيحصل loss لantithrombin 3 في اليورين و at the same time heparin محتاج for its anticoagulation effect antithrombin 3. هنا السامبل سايز كانت 16 patients, half اخذوا rivaroxaban والhalf اخذوا low molecular weight heparin والprimary endpoint هي thrombus dissolution. الobservation ان في اول week الاثنين both showed similar results. Yet in the patients اللي وصلوا للprimary endpoint كانوا أكتر في patients اللي أخذوا rivaroxaban و that makes sense لأن theoretically rivaroxaban is independent على antithrombin 3. Yet this study showed different result. In antithrombin 3 returned back to normal for week 2. This could be related in the patients حصل لهم nephrotic syndrome remission فالloss بتاع urinary antithrombin 3 بقى أقل. or ان هم اخذوا corticosteroids فده زود وعمل promotion للسynthesis بتاع antithrombin 3. The limitation of this study in هم كانوا 16 patients. Antithrombin 3 was not persistently low throughout the whole study. Plus in the urinary antithrombin 3 level was not tested to verify هو اللوس ده حصل بسبب nephrotic syndrome or any other type. The results in the rivaroxaban may be effective as treatment and prophylaxis in nephrotic syndrome patients. We show good compliance yet احنا محتاجين future research عن السيفتي. لسه مكملين في الدواكس used in nephrotic syndrome, safety versus efficacy. هنتكلم على الكيس ريبورتس اللي استخدموا الدواكس في nephrotic syndrome. أول case study كانت في 2019 كان poor response to rivaroxaban in nephrotic syndrome patient with DVT. The point is in a male patient حصل له DVT during early course of nephrotic syndrome. أخذ rivaroxaban oral therapeutic dose. It was he showed poor response, so they switched him to heparin followed by warfarin. Outcome can improved outcome regarding venography and regarding edema disappearance. And this poor response could be related to the pharmacokinetics of DWACs. DWACs are highly protein-bound drugs. So ممكن يحصل في nephrotic syndrome high urinary protein loss فالdrugs thin in blood causing toxicity and causing bleeding risk أعلى. or ان الدرج والبروتين بيبايند together وبوث بيحصل لهم loss في اليورين فكده هتقل ال concentration of the drug في البلود فتقل ال efficacy وتقل ال THAF. So that's a challenge how to monitor. الدواكس بتديني immediate anticoagulant effect yet دول highly protein bound drug فبيقللوا ال concentration of the drug وبيحصل له loss in urine. So is it enough ان انا measure the serum concentration of the drug or ان انا measure factor 10? Yet to be noted in nephrotic syndrome secondary to the hypoalbuminemia بتحصل increased hepatic production and increased activity of the clotting factors. So it's still questionable and debatable. But by the end of the day, we have to educate the patient regarding the safety, regarding the side effects of the drug, and ask them to monitor and to report any minor bleeding effect. Another case report عن recurrent venous thromboembolism in nephrotic membranous patient despite ان هم اخذوا apixaban therapeutic dose. Patient جاله DVT أخذ apixaban 2.5 mg twice daily yet 2 months later حصل edema وحصل through the CT لقينا فيه clot extension. فhe was discharged على apixaban 5 mg twice daily as they thought in the prior dose was subtherapeutic. The outcome in despite the appropriate dosing of apixaban, the patient developed recurrent venous thromboembolism. آخر study كانت في 2021 هي posted في 2021 عن الابexpan used as prophylaxis in patients with nephrotic syndrome. ال 27 patients were estimated and published from 2018 ل 2020. عملنا follow up after 153 days ولقينا ان 3 out of the 27 patients developed thromboembolism at time of nephrotic syndrome diagnosis, 2 developed pulmonary embolism, 1 stroke, 1 pulmonary embolism after introduction of apexpan by 2 months, and 0 minor or major bleeding. الconclusion by the way هنا ال patients أخذت apexpan as a prophylactic dose 5 mg twice daily. وكان بس reduced dose to 2.5 mg twice daily in patients اللي الage بتاعها أكتر من 80, body weight less than 60, serum كريات أعلى من 1.5 mg per deciliter. The study showed إن حصل reduced risk of venous and arterial thrombosis without risk of bleeding. So here's the drugs used in nephrotic syndrome timeline. في 2017 قلنا it's possible rivaroxaban is a good option to be used. 2017 و 2019 كان case reports قالت إن حصل poor response. في 2021 قلنا it could be used as prophylaxis بtherapeutic dose و showed better result. فاحنا دلوقتي محتاجين future research عن ال safety وال efficacy of drugs in nephrotic syndrome. The take-home messages in all nephrotic syndrome patients, the decision to prescribe a prophylactic anticoagulant must be balanced against the risk of bleeding. Prophylactic anticoagulation should be avoided in patients with high risk of bleeding. Drugs are more favored over warfarin, yet we need more study against to assess the safety and the efficacy. We have to educate the patient about the treatment adherence and the lifestyle modification. Thank you.